Good evening, everyone, and thank you for joining us tonight. Before we launch into Mary Anne's talk, I wanted to share a few reminders. First, this month we'll be opening our Leadership and Surgical Education Fellowship applications for next year. The Leadership application will be open to anyone who will be a colorectal surgery fellow for the 2023 to 2024 academic year. The Surgical Education Fellowship will be open to general surgery residents, and preference will be given to those interested in colorectal surgery as their future career. Now, without further ado, I am thrilled to introduce Mary Anne Obst as our speaker tonight. I learned so much from her in residency, not only in wound care, fistula management, and stoma troubleshooting, but also how to gently guide patients through complicated and painful dressing changes, ensuring they have agency. She is truly unmatched in her experience and expertise, and I can't wait for you all to learn from her tonight. A native of Minnesota, Mary Anne graduated as a nurse in 1987. She has extensive experience in ICU nursing and spent many years as a flight nurse. Mary Anne's experience at Regents Hospital in St. Paul, Minnesota includes being a staff nurse in the SICU and a trauma nurse clinician. She helped establish clinical research efforts for the Regents Hospital Department of Surgery and has coordinated multiple research studies. Mary Anne and her team established the Complex Abdominal Reconstruction Service at Regents Hospital. This team has developed novel and structured approaches for managing complex abdominal wounds and enteric fistulae. The CARS team focuses on optimizing patient outcomes and quality of life on the journey to surgical repair. Currently, the team has over 200 patients and manages all aspects of patient care, including nutrition, conditioning, surgery, and wound care. In addition to her clinical work, Mary Anne speaks nationally and internationally about the challenges of fistula care and complex wounds. She is the creator of Fistula Solution products and holds 3 patents. She has published articles in multiple journals, including the Journal of the American College of Surgeons. And tonight she'll be teaching us how to manage difficult stomas and fistula, offering key points to success. Take it away, Mary Anne.
Thank you so much, Dr. Boble. It's so great to be here. I'm just thrilled to be talking to you guys. So I think I'm going to start with a little introduction on my crew, as I'll call it. My husband and I, Andy, live here in Scandia, Minnesota, which is about 2 or 3 feet below snow right now. We've had a ton of snow. I have 4 children. This is my youngest, Jack. He likes to 4-wheel and surf and that kind of thing. My daughter Rose is now at the University of Minnesota in the engineering program. My son Tyler just found out today that he's having a baby boy, so I'll be a grandma number 3. My older daughter Amanda is married. She has 2 children, Lily and Willa, and I have 2 amazing dogs. My favorite photo of me as a flight nurse is this from, I think it's 1989, so it kind of dates myself, but this was the S-76 Sikorsky, and it had 2 pilots, it had 4 clinicians in the back, and we could take 2 patients. Super fun. So let's talk about my real passion in life, which is ostomy and fistula care, and it can be really fun if you have a plan. And so that's what we're going to talk about. There's no way we can give you all the information about fistula and ostomy in one evening, but I want to plant a seed in your mind that, there is things out there to help you. So this gentleman, Professor Carlson, in the Intestinal Failure Unit in Department of Surgery at the United Kingdom, wrote an article in 2016, which was written again in 2017 or 18. And he talks about SNAP, and that's really how we started our program, using the mentality of SNAP. So what does that mean? It means that you're tackling the problems at hand that you need to first. So skin and sepsis is, number 1. You have to identify a way to give these patients nutrition right away, and then define fistula anatomy. And usually that takes, a week or 2 after you identify a fistula, and then proposing a procedure to address that fistula. And I encourage you in your new life as colorectal surgeons to build a team that's beyond what is probably going to be given to you by your facility. The CARS team was not something that we put together with a budget. It was something that we built because we believed that if we met every month with all these different specialties, that we could really make a difference. So every other week, and Dr. Boble came to many of these, we'd sit down and we'd run through our difficult patients and let everyone kind of weigh in on what direction they thought we should go with that patient. So we know from the colon and rectal literature that if the fistula doesn't close in the first couple of months, it likely won't close. Those ones that close spontaneously, and we kind of talked about SNAP, understanding the anatomy and getting them good nutrition and handling sepsis is the best way to make that happen. But if it doesn't happen, those are the ones that are going to be in your office and in your facility for weeks and months and so many visits that I want to help you guys get a plan for those types of patients. So this is the challenge. Even if you don't feed your fistula patient, which I really recommend that you do feed your patients, they still have a lot of effluent and succus coming out. You know, I mean, the small bowel, saliva will still secrete liters of fluid if you don't have your, GI tract intact. And so the first thing in our SNAP mentality is handling skin. And I like to clean with a solution that actually is going to knock down fungal problems, bacterial problems. So hypochlorous acid solution is awesome. There's new skin protectants out there that last for like 3 days. I highly recommend you guys to get a hold of those for these types of patients. And then you're going to make a fake skin layer. And likely this won't be you as surgeons, but I want you to know what your wound nurses will be doing. This isn't easy work. And so you have to make like a layer to land your pouching system. So then we put the pouching system over that fake skin, and then we seal it again with another layer, and then we put a big pouching system on, and they can stay in this. Even though there's fistulas or even a wound, they can still stay in a manager like this. These products are called fistula managers. So when we get to nutrition, you really need to start your nutrition almost like a trauma patient, like as soon as possible after whatever the event is that's preceding your fistula. And so a lot of times that's TPN, start enteral feedings as soon as possible, and really consider your fistulolysis down the road. We have a patient example that I can show you, fistulolysis. If you're more unfamiliar with it, I can definitely take any emails after this as well if you need help. And then find a nutritionist that is very versed in short bowel. It's not easy to find, but usually there's one of your nutritionists that loves it. And then, start to evaluate your patients. There's no perfect laboratory evaluation. And what I always tell our teams is you have to look at the trends. One lab value will never tell you anything, but as you take them in a kind of a stepwise fashion, at least you'll know if you're going the right direction. So high output fistulas, and that's only over 500 cc's in 24 hours, need a ton of calories and a ton of protein to heal what's happening around them. So whether it be wounds, surgical incisions, and remember that they need lots of vitamins. So 10 times the normal vitamin C is just a tip of the iceberg. Nutrition, Carol Parrish is a nutritionist on the East Coast. She's amazing. And she started the shortbowelsyndrome.com website. This book called Managing Short Bowel is in its 5th edition. It is free to your patients. You just log on to the website, put in their address, and they will actually mail it to your patients. And the reason that that's so important is because your patients, when you start to talk about short bowel philosophy, like you can't drink anything during your meals, crushed, you have to have all your meds crushed, you have to take the meds 30 minutes before your meals, you have to drink Pedialyte throughout the day, but not during your meals, no juice, no water, no soda, no ice. You have to chew all your food well. We like do chewing evaluations, add salt to everything, and then find your great nutritionist. It really helps to have this book to back up the fact that this is really important. And this is like life-changing, managing this short bowel syndrome. And then make your own medication protocol. This is just ours. And this is obviously a slide of it, but set a goal for your patients, whether they're a high output ostomy or a fistula patient, and then start your medications in a stepwise fashion. We like to max out one over several days. Not making too many changes at once is super important to figure out, if you all of a sudden have control of your output, is it, the patient stopped eating, or is it the medication? So really pay attention to what's happening every day, and then just keep adding your medications as needed. There's a fairly new medication on the docket that you can possibly use. And the interesting thing, this is a GLP-2 analog. It increases the villus height of the bowel, so you have like more uptake. So how they explain it to me is like, if you have a bowel, you'll have 30% more surface area to absorb fluid. The thing that you guys have to remember, especially as colorectal doctors, is that it will also grow cancer. So we have to make sure we screen our patients really well before we put them on this particular medication. We've seen amazing outcomes with this medication for some of our high output fistulas. And then, like I was talking about, sometimes you're doing everything right? You have the right food going in, you have everything's being documented appropriately, but the patient still has a very high output. I mean, I never hesitate to try to check for C. diff. And I know that at least at our facility, there's some rules about how often you can check for that. But in this situation, it's something you might want to think about first. And if you really can't figure it out, you just got to pause, take everything away, make them MPO, try to give them just the minimal amounts of IV fluids to keep their kidneys happy. Explain to the patient that you're going to do this pause for the cause to figure out how much output they have in 24 hours. And once you figure that out, then you can slowly introduce foods and fluids to see how they do with those. And never forget about the ice factor. Nurses have huge hearts, and the short gut medications make these people have really dry mouths. And so it is not uncommon that some large-hearted nurse will give your patients ice chips, or the patient will go into the bathroom and drink out of the faucet. So we've kind of seen a little bit of everything. That's why you really need to take the time to sit down and explain to this patient why you're doing this. And then if you don't have this app on your phone, I highly encourage you to do it. It's free. It's from the Carolinas hospital system. And it's just a quick flip through looking at your patient's modifiable risks. So it's literally this easy. Have you had a hernia repair? Do you smoke? Is there an infection? Are we going to do advancement flaps? And with that information, you can see your risk. So this patient had a 47 or 46% risk. And then it allows you to edit answers and really find those modifiable risks. And I show the patients in clinic when we're doing this. And so you can say, look, if you quit smoking and you get your A1C under control and you lose 20 pounds, you could decrease your risk by, another 25%. So it's a great little tool. We document it right in our progress notes. Okay, so we're still doing SNAP. So anatomy is next, and we do several different things. Our first time, generally speaking, is an abdominal CT, and they usually have had that before, our team even gets involved. And then a fistulogram is what we'd call an IR study, where we actually intubate the fistula and then inject dye to see what the pattern is of the bowel itself. It's super important to have a team member there. You just don't get the same information when it's just on your, chart. And so we try to make sure somebody attends those fistulograms. And the same for fluoroscopy. The upper GI or the, small bowel follow through. There's two problems with it. Patients hate it because it's uncomfortable on that hard bed and they have to turn side to side. And it takes a ton of time. And I think a lot of times we forget to tell them, this is a long study. It could take several hours. Be patient. It's going to be really helpful for us to understand how many centimeters of working bowel you have if we can get that study. With that being said, you also have to have a team member there to encourage the radiology staff to keep going until the dye comes out into the pouch. And sometimes that can take several bottles of contrast. And so you got to really encourage them to keep on it. The other thing that we talk about a lot is if you're unsure of exactly how intact your bowel is, stay away from your bariums, even though the imaging is a little more crisp if you use barium. But for this small bowel series, I would use something that's water soluble, just so it doesn't escape on you. And then obviously colonoscopy, contrast enemas are the other things that we kind of do closer to the surgical procedure. And the reason we need to know if there's continuity or not is because these types of diagrams of what the bowel can do when it's unplanned is going to drive our management as, for sure, as wound care providers. So if there's continuity with the rectum or the distal bowel, Then we're going to do a temperature of closure. So we're going to do things like anti-gas, make sure that there's no back pressure in the bowel. We want to decompress the bowel, make sure that they're eating foods that keeps everything going through. And then we're going to use dressings to close that fistula. Now, if there's no continuity with the distal bowel, or you just don't know because you haven't had the studies, it's much safer to give shortcut meds, isolate the fistula, heal the wound, and plan for your surgery 12 to 18 months down the road. So fistula clysis is, it can be difficult, but it's amazing if you take the time to do it. This little gal had been on TPN for like a year and a half. She ended up in our facility for another reason, and she had a fistula. So I was pouching her fistula. I'm like, you have a fistula that looks like, it goes over to your ostomy, should we check to see if we can just put a feeding tube in there? Maybe you could get rid of your TPN. And sure enough, just with another 120 centimeters of small bowel, we got her off TPN, and then you just run the tubing right through the pouching system. And so this is the fistula clysis. So this is where the bowel goes to the ileostomy, and this is where the poop comes out of the fistula. So that's another reason why it's nice to have team members, wound nurses, whatever, attend those studies, because they know which hole is the active hole, if you want to call it that. And it really helps the radiologist. So we did a little research in our colon rectal department in 2017 and 2018, looking at preparing our patients for surgery, trying to have the healthiest patients and provide good outcomes. So we added 2 products. These are the products they're masks, obviously, but we saw a reduction in average length of stay and readmission rates pretty pronounced. And so this was a grant that we had gotten through the Health Partners Foundation. And because of this information, we actually made it part of our surgical order set. So it was really easy for the surgeons. It was pre-checked when you put in your order request. So you could uncheck it if you didn't want your patient to have it. And then it would ship from our central pharmacy right to the patient's house with the directions intact. And it just made a huge difference on our outcomes. And then P is definitive procedure. And, generally we wait 12 to 18 months. Some people are waiting longer. But you can't forget that sometimes the definitive procedure isn't that final surgery. It could be a soft tissue revision, which Dr. Boble actually had presented at the CRS conference. I think it was last year, but I can't say for sure. And then the operation, you really need to think about, what is the ultimate goal? And I know this is Dr. David Dries. He was an amazing staff surgeon at our facility. And he always said that the number one thing he needed to do is make sure that the bowel was put back together. And then you can always go back and do abdominal wall reconstruction. So this is a program that if you're interested in starting, I would encourage it in your facility. It's engaging family and friends early, have them get their cell phones out, videotape how you put on pouching systems, how you're doing different techniques, have them administer their own short bowel medications in the hospital, which is something you have to get through leadership. Self-documentation of output totals and really see if you can grow a fistula or ostomy support group that can help your patients. So this is the cutest little lady ever, Marla. She's 92 now, and her daughter-in-law, Elaine. And Marla's had a fistula that one of our colon rectal surgeons put back together. But I was there in the clinic when he was talking to her about the risk that he would have putting her back together at this kind of frail, she was 89 when he actually did the surgery. But she really insisted, and he did it. And I just wanted you guys to hear her story.
I'm doing great, and I can't explain how wonderful it is to be free of that second that fistula that I had, and having that pouch. It had to be changed 3 times every week unless it leaked, and then there was more changes, and it was so painful. Many times I cried while it was being changed, and sometimes it took an hour if that fistula was not behaving itself. Now I am free of it, and I don't have to worry about it. My tummy feels better. I can go without worrying about it leaking. It's just great. I could not eat salads or popcorn. Now, can I eat popcorn, by the way? Now I can eat anything I want, and I'm just about to try the popcorn without the husks in it,
right?
And the salad.
Perfect.
The chef salad.
Have you had the chef salad?
No, and I don't want to go into the hospital to have the chef salad here. And this is where they had the best chef salad. It is very important to have a consistent person who knows how to do it. And this gal spent an hour one day doing it because of the fistula was not behaving itself, and she kept on doing it. And I couldn't have done it without her.
Yeah.
I couldn't have survived without her. I will celebrate my 90th birthday this year. The actual birthday's in November, but we're celebrating on Labor Day. My family is coming together. They tell me they have a Jeopardy game all in place, and we're also going to auction off all the things that I can't use in my apartment now. I have a crazy family. You would all love to be at the birthday party, I can tell you that.
When I sat down here, I started to get a little teary, thinking, well, what is that about? And it's really about that letting go of feeling that extra responsibility that I had to be within, some close distance. We moved her into a studio apartment in the assisted living part of Eagle Crest. So she's back at a place where she has friends. I had to almost tie her down to not run away while we were trying to put things away because she wanted to go see her friends. Watching her take flight now back into being her own person and making the list of things that she wants her son, my husband, to stop and pick up before he comes over, and so that she can be independent. That's a huge gift. I appreciated his honesty, to be honest, to hear a surgeon of his caliber and kind of understanding the delicacy of the surgery. I appreciated his honesty. I really did. Because we were going into it with open eyes and understanding if it went well, hallelujah, we'll get on with life. And if not, we'll still get on with life, but it'll be a different environment.
I took a risk. I wanted to give myself a chance at a better life. And I'm enjoying it now. I'm doing great.
She is the cutest thing ever. I did attend that 90th birthday, and I don't know if you can see, but she's actually wearing a 90 tiara, which is just totally her. They did auction off her stuff. I didn't actually buy anything, but I thought about it. Okay, so we're going to go into a gentleman that was brought to us by outside hospital with some ischemic bowel after an elective colostomy he was a para. So he was at outside hospital. He was having some incontinence issues, and so the surgeon just encouraged him to try a colostomy to make his life better, which is wonderful. But unfortunately for this gentleman, it didn't work out. He had an anastomotic leak, was flown to us. We couldn't get his abdomen closed. And so by May 11th, we put over from skin edge or sometimes toe fascia edges, just like a mesh, like a synthetic mesh. And then we just allow the patient to granulate through that. So part of his story is he did have a diverting ileostomy. And so on May 10th, I get called a lot to look at stomas that they think are dead. And I guess one of the things I want to give you guys as a pearl is, don't give up on your stomas too soon, because May 10th, this is what the stoma looked like. And I'm like, it's going to be fine. On the 14th, it looked like this, but by August 11th, obviously it was totally normal. So I always just say, just give it some time, and as long as there's, the rest of the body is being healthy, it's probably going to work out just perfect. So this is what it looks like when they granulate tissue through the micro mesh. We kind of clip away what we don't need, and then we put them in a negative pressure system to get them ready for skin grafting. Unfortunately for him, he popped a fistula through on July 6th. And so we knew that we're still going to skin graft, but he'd have to skin graft up to the fistula. So this is what it looks like when you're putting on a fistula pouch. I'm going to turn the volume off. And so I'm just doing a technique where you're protecting the skin on the edges. And there's always some amount of fistula output that comes out during it. And I had this nice little gal helping me that it was like her second day. She was a PCA. She was new to suctioning, but the stuff that's laying on the wound is a collagen that is almost like Surgicel. So it has silver and collagen, and it heals wounds, but at the same time, it'll stop bleeding when you're putting on dressing. So if you're ever taking care of a patient's wound, I can give you the information on what that is, but it's really nice because it stops the bleeding. You just leave it in place and then you put the dressing right up and over it. So this is an isolation device to allow the negative pressure to prepare the wound bed for skin grafting while also keeping the stool contained in a pouching system. And it's always a little hairy when you're putting these on because you're kind of under the gun because it always seems like the fistula goes crazy right at the last second or two. And so we're sealing this up, cutting a hole, and we're going to put a pouching system up and over the top of this after we get a seal from our back, which obviously had a hole right there. And then we just put paste on the inside, a little bit of powder on the inside, and a pouching system right up and over the top. I usually use a little barrier ring. I'm giving you all the lingo. That's a barrier ring. It's a 2-piece pouching system. And then we'll put him in a high output pouch so that he has 2 to 3 extra liters of space, because an ostomy pouch holds about 350 cc's. But you can always connect the high output ones to like a bag on the bedside, and then they'll have lots of room to collect their stool, because he was putting out about 3 or 4 liters a day at this point. So a technique tip is using a barrier ring on the backside of the isolation device. And then we did get him skin grafted quite nicely. The burn surgeon was unsure of skin grafting right up to the fistula. She's one of our newer ones, but he still looked okay. So we got him into just a very simple 2-piece pouching system. As you can see, we put a pouch on here, obviously. So one of the things I wanted to point out is some people's body shape doesn't allow them to wear a belt, and some patients need a belt to keep their pouch on. So one of the ways to get around that is to use these old-fashioned, they're called Montgomery straps. You may not have ever even heard of them. And instead of a belt, you're going to hook the Montgomery straps to the belt loops in the ostomy pouch, and it just gives it a little bit more mechanical strength. We developed a dressing change checklist that really kind of broke down the time prior to the dressings, notifying the surgical team that it's going to be changed. We give pain medication for anxiety and pain if needed, and a medication to decrease bowel function. I always will give tincture of opium before I change a pouch that's high output, because it just gives me a little bit more leeway where I don't have stool kind of flying all over. And then making sure you have suction, and then photograph the backside of your pouches, because it really tells a story of if you were successful, awesome. If you were maybe a failure, where the failure points were. So this is an infected mesh case that we had 2 years ago. Kind of the normal story that you guys hear with all your patients. You know, they have multiple different surgeries coming up to, you know, before they see you. This guy started with eating a chicken bone, which didn't seem like the best idea. And then he had multiple hernias after that. And he came to see us in October. So we knew he had a fistula because they had sent us a CT scan prior to him arriving. And he came to clinic with a suitcase. He was about 8 hours away in another adjacent state to come to see us. And we just were like, you're not doing surgery today. And he was shocked, actually. So we did a CDR app, and he was at 87% for complications. And really his biggest thing is he needed to lose some weight. So we sent him home with a weight loss goal of BMI of 40. And he did really well. He lost like 60 pounds. Unfortunately, his fistula really erupted. We had some challenges, like he wasn't able to read. His surgeon didn't have an ostomy nurse. And so I was sending them products from Regions, and I would sticker them in colors so that they would know which thing to use. And when I was on the phone with them, I could say like the thing that is stickered with red. So like really trying to figure out how to optimize this patient at home. All that being said, we decided to bring him into the hospital a whole week prior to his surgery to optimize him before his fistula takedown. So he came in on March 16th, which is the day before COVID shut down our hospital. And so this is what he looked like. I took off his last pouch. We're, high-fiving because, it's the last pouch you're gonna need. Tomorrow you're not gonna have a fistula anymore. And it's kind of it's a big day. And I said, well, call me when you get out of the shower and I'll come back up and put your last pouch on. And he's like, okay, great. So he calls me and he says, something's sticking out of me. And I'm like, oh, okay. And he said, I thought it was a piece of ham. And I'm like, all right. And he said, so I gave it a tug. And he goes, but I didn't get it out. And I'm like, oh, okay. And I went up there, and this is his ham, which is also a piece of infected mesh that he pulled through his fistula. So the next day we did take him to surgery, even though all elective surgeries had been canceled. We went to leadership and said, oh my gosh, we have to do this, gentleman. We've been working on him forever. And so here's his piece of mesh or infected ham. Here's where his fistula was. He lost a little bit of small bowel. We did bilateral external oblique releases, and we did a large piece of retrorectus composite mesh. We staple our skin closed in groups, and we leave gaps and put white foam wicks in them, and then we clear drape the entire abdomen, and then we put this big bolster back on, and it does a couple things. It really does help with pain, and it helps to bolster the incision in patients that we know won't be able to wear an abdominal binder very well. We take that off in 2 days, and we put on an incision management system, a closed incision management system, and then we take that down 7 days later. And then we saw him in telemedicine after that, and he never came back to the hospital, and he's doing fine. The closed incision management systems, if you're not used to them, there's several on the market now. They do provide mechanical stabilization. They protect from physical, the bugs of what's going on outside of, the patient, if they poop on it or whatever. They reduce edema, which is so helpful in your closed incisions. They increase blood flow and lymphatic flow, and they reduce your hematoma and seroma. And we feel that they really decrease pain. So look into your system and see where you have one of these. They are a godsend for incisions, especially posterior incisions, like that they sit on or something like that. It really makes a huge difference. So this gentleman, back to our patient, we had a lot of pandemic challenges. They closed down the hospital. His wife was there with him alone. So we put his wife in one of our doctor's apartments. We had to fix his truck. They had guns in the truck. We had to case the guns. And then finally, when we were going to send him home, they really didn't know how to get out of the city. And so me and one of the other nurses jumped in the back of their truck. We got them through Spaghetti Junction and sent them on their way. And this is a picture of me and the other nurse sitting in the back of the truck. And then we walked back to the hospital. So you just never know what's going to happen with fistula patients. They're just such a wonderful challenge. So this is an open abdomen case that he had a nephrectomy, small bowel obstruction, came back in, had multiple PEA arrests, had compartment syndrome. They did decompressive enterotomies at the bedside. They ended up with micromesh to skin edges. And this is when they called me because he was just draining a lot of serous fluid. So much like the other patient, the granulation tissue kind of grows through this mesh. I just put them in a big pouching system. So this is the fistula manager. So if you're ever asking for something, that's what you're looking for. And it's amazing in just a couple of days of moist wound healing, how healthy the tissue can look. And in this point where, you're like, should I put a vac on this? And you're standing there scratching your head. I would say no. I would say wait for the bowel that's all inflamed to settle down. We know there's sutures and injuries underneath there, and just put them in a big pouching system for a couple weeks. It will always serve you well. Once it looks like this, and you can't really distinguish the loops of bowel anymore, you have granulation tissue covering all of it, then you can think about negative pressure. I would still put down a non-adherent contact layer. I'd use low pressures on my vac, and that can really make a huge difference with these patients. Unfortunately for him, where we did some of the decompressive enterotomies, he ended up with little cute fistulas. I thought there was a fistula up here. Here's his belly button, but he actually had another little fistula right here. So we moved to negative pressure system. We were isolating the bowel in a plan for skin grafting. We want to contract that wound, but we still want to contain the poop that's coming out of his fistulas. And so this is just a technique tip on how to use the products. And so here's this little fistula on the side and the bigger fistula down below. And you can just tell, this is the same day. This is in the morning and this is in the afternoon. You can see that this fistula obviously is the one that's closer to his stomach. He went in for skin grafting in September. We put him in a high output pouch in the operating room. We've learned to not use post-op pouches in the operating room for fistulas because their output is so high. By the time they get to their nursing unit, they blow their post-op pouch off and the entire negative pressure system comes off and we lose the graft. So he was ready for surgery a couple months later, and this is him post-operative. Now he's got a message for you, and I think that he's one of the most well-spoken patients we've ever had. So I just wanted you to have the opportunity to hear from one of your own patients.
Well, from what I remember, I had kidney surgery, and I came for a follow-up, and I wasn't feeling well, and I felt like I was going to pass out. And luckily for me, I had my 16-year-old daughter with me that was eager to drive me to my appointment, and I was at the specialty clinic, and they brought me to the hospital, and all hell broke loose from there. But I think the most challenging part was going home after I left and actually laying on my back and watching my wife kind of change that bag every day and being careful for me not getting an infection. And actually one day standing in a mirror just before I went into the shower, she goes, I'm gonna just open this bag for you so you can see how gross it is. And oh my God, I thought I was gonna pass out. That was the very first time I could see how bad the situation was. She had an idea what she was getting herself into, and I think she's a very patient person, so probably you saw that in her, and she's a very caring person, so probably that's why she was able to be as calm and learn. Trust me, she had that little iPhone in her hand, she did her research, and she knew a lot of things to do before we even got home. But I think it was easier because it was somebody that you know that cared about you, and it was your wife, and you know that she was gonna have your best interest at heart. So it was just easier for me to just do whatever she wanted me to do and do the best job I could for her. A year or so afterwards, she didn't want to show me how bad it was till she felt like I was out of the woods, so to speak. And then she can literally like show me pictures and cry. And that was when she kind of broke down, and it was my time to kind of take care of her. So I felt like I had to be strong for her, because no matter how strong you are, everybody have their moments of weakness. And my biggest fears was I didn't want to have a bag for the rest of my life. Yeah, I was afraid about the bag because I'm a physical person by nature. I like to work out, I like to do. If you tell me I can't go on a bike ride, I can't do any of those things that I love to do, what's the point of living? And yet people that have this problem have a bright future, because there is a light at the end of the tunnel. It's hard to see, but eventually, if you go on a long distance ride, you can't see your destination. It's a journey. Eventually, you're gonna get there.
Right.
How you get there is entirely up to you. You gotta trust in the people that are taking care of you, that they will do the very best they can to save your life. And I think my belief in God and my trust in just talking to you sometimes and talking to Dr. Dries and Dr. Schaefer, I just felt like I had a fighting chance.
So he's an amazing,
From what I remember.
he's an amazing man, and definitely wanted you guys to hear his story, because I think for sure in residency, you know, you guys get moved around a lot and you don't get to see the start to finish. You know, we're like an 18-month to cure program, so we're lucky enough to see that whole thing. And I just thought it was really powerful what he was trying to say to you as young colorectal doctors. So I hope you enjoyed that. So our last, I think that's our last case. Here's a 51-year-old, had another abdominal disaster, kind of like the other one. I guess that's kind of a theme with our patients. He had a Kugel mesh that fractured and ended up flown to us with a abdominal abscess. So they did a release and a bunch of pus came out in sutures. But unfortunately for him, his fistula was hiding underneath his big abdominal wall. So the nurses called me and said, hey, I think there's poop on this guy's wet to dry dressings. Can you come take a look? And sure enough, I lifted it up and you could see there's this cute little fistula just hiding underneath all that adipose. So I can't really take care of a fistula that it can't see. So you really need to find a way to make decisions in your practice about how to handle these. So if it's the question is it under or impeded by soft tissue, right? I mean, that's one of the big questions. If yes, you really do need to remove that soft tissue to expose the stoma. If no, then is there a wound? Because if there's a wound, you can just use bolstered pouching techniques. If yes, you might want to use negative pressure, like we talked about when it's appropriate. If no, you can use a wound manager and just reassess every couple weeks. But if yes, they probably will need a skin graft, and you want to probably get them ready for grafting at that point. So that's just what we did with this gentleman. We exposed his fistula, putting him in a big pouching system with a technique we called the sandwich technique, where you sandwich the pouch between two of these sticky barrier rings, and then just moist wound healing. We took him in for studies, figured out where his, and this is why it's so important to have a team member there. His high outputs were over here. These guys were all downstream. And so after, a couple of weeks, he came in on New Year's. And so this is February. Now he's still in house. We put him into negative pressure, getting him ready for, whatever he would need. And then into a big pouching system. There's many different techniques, as you can see, for putting on these dressings and containing the stool in combination with negative pressure and these fistula managers. He never was put on TPN or anything. He always ate all of his meals, and he did a great job. I mean, he really owned his own world. So this is what it looks like. I hope that you guys find this interesting. April, here he is in May, June, I lost June, I don't know how, July, and August, we took him back to surgery. So in 8 months, he kind of went from this to this. And we took him into surgery. This is the way the incision was made. Here's the top part. This is the infected Kugel mesh. This is the back part of the fistula, and we flipped the Kugel mesh. And this is what he looked like at graduation day. So here's one more video. I think this is our last video. This is Jim Schlafer. He's a general surgeon that worked on the CARS team. And this is Kristen Linval. She was the surgical PA that worked for our team. And then you're also going to see, these guys are going to talk, and then you're also going to meet the patient that you just saw, which we call Big Mike. I should tell you that. You're going to meet Big Mike, his mother, and a physical therapist that I talked into taking care of him 6 hours from our hospital in a small town in western Wisconsin. He had never seen a fistula before. And I went out there and taught this physical therapist how to assist in putting on the pouching system. And Big Mike was never readmitted to the hospital until the day of his takedown. So I'll let Dr. Schlafer take it from here.
My name is Jim Schlafer. I'm a general surgeon.
And I'm Kristen Linval. I'm the physician assistant that works with Dr. Schlafer in our complex abdominal team.
We learned a lot of stuff from Big Mike. He had a major problem with his abdominal wall. He had infected mesh, and he had a huge fistula problem.
I think the patients that is fistula care, Big Mike, he did a fantastic job of owning his situation and really being invested in his care. Mike lost a lot of weight, and he did everything we needed him to do so that when Dr. Schlafer brought him to the operating room, he had his best chance at a really successful procedure. I think it's hopeful because we've been through the journey with them, and we know everything that they've done and we've done to get them there, and that's really the end of the road. So it's a good day for all of us. We anticipate that we're going to be in there a long time for them. It's not a short time to get to the operating room, and it's not a quick case. But I think the cool thing is that we can get people there and the quality of life that they can get back. It's pretty phenomenal.
There was a lot of planning that went into him. And what we've learned is waiting longer is a better thing, and it sometimes takes a whole year before you can operate on somebody with a fistula. My name is Jim.
Okay, I guess Big Mike's part of the video didn't work, so we're just going to keep going. Sorry about that. So this is something that Dr. Boble also presented, and so if you want to jump in and say anything, please feel free to do so. But we started something we called RISP, which is Revise, Isolate, Skin Graft, and Pouch. And so it's revise the soft tissue, isolate the fistula, skin graft up to the fistula, so that you have a pouching system that these patients can go home with. And so this is just an example of a RISP that we did actually many years ago. So this is a ileostomy downstream. This is her fistula, and she contracted her wound right up to the fistula. And so she had all these big creases all over. So it was really difficult to pouch. And so we actually took down tissue, put on a negative pressure system, allowed that wound to heal right up to that fistula. And she did great in just a general pouching system after that point. So we thought that there probably is some kind of mathematical equation to this, because we had a patient that we were working with that had to have multiple, what we call RISP surgeries. So here he is. He was a motorcycle accident. Here's his open abdomen. He had a pelvic fracture. He had leg fractures. This is his ostomy that was a diverting ostomy after surgery, but it fell underneath the skin completely. So we don't have a picture of that, which is too bad, but it was like the hole for the ostomy is over here, and the actual bowel was underneath the skin, which is obviously something he couldn't live with. So we took him back and we did a RISP procedure, but unfortunately, because this guy was such a good healer, he kind of healed up to the stoma again. I'm sorry, this is not a fistula, this is a ostomy stoma. And so we went back to the OR, and this time we really looked at the planes that we had, and we made a plan on how far we had to go from the os of the stoma through the soft tissue to make him into a candidate for good pouching. So we took him back in September. We put down biotemporizing matrix as a neodermis grower. We did it around both the abdomen and the stoma, put on negative pressure. We skin grafted him. This is what a skin graft looked like. All in the whole reason we did all this is so he could go home and heal for a year or year and a half. And we got him into the easiest pouching system ever. And he was never readmitted. And that's really our goal with doing RISP, is to get them into a place, whether it's a fistula or a stoma, that you can get an easy pouching system on that's reliable, so they can go home and eat and recover from whatever the incident was that brought them to this point. So this is just another example of just different types of pouching that you can do. We call this the pouch flange sandwich. You can call it whatever you want, but again, it's cleaning everything up, putting down a barrier ring and a pouch over the top of it. We also use negative pressure a lot. So this is a patient that has an open abdomen. This is it's her stoma, but it fell underneath the skin. So we cut down soft tissue, and then we finally ended up skin grafting her so she could just be pouched primarily. Sometimes you have patients like this. So here's her ileostomy. You got a nice incision here. Unfortunately, her incision kind of started falling apart. Her ostomy, kind of the os of the ostomy was right here, so everything would shoot out the side. So sometimes on the weekends, if people are exhausted, I'll put them into a negative pressure system with the pouch over the top, just to give them a break so that they don't have any leaks or anything. They can, wear it easily for 3 days. So just something to think about. So the ASCRS and the WCN consensus statement for surgical perioperative stoma site marking came out last year, and it said that there's 5 factors associated with peristomal complications: age of 65, female, BMI, diabetic, abdominal malignancy. Those are the things that can cause complications. The 2 things that can help decrease your complications as stoma site markings by a WOC and follow up with a WOC within 2 weeks after discharge. And then I thought it might be interesting for you guys to see how we're taught how to do this. And this is really right out of our book. It just teaches us where to mark the patient, thinking about topography, positioning issues. Do they have a contracture? Patient considerations, had they had a stroke, surgical considerations, multiple stoma sites. Really try to think through all the different problems. This is the pictures that we are taught. We're to go under the line or stay away from the avoid the under the line of sight. They want us to make sure we know where the ribs are and where the rectus muscle is. And I can tell you, this is not always easy. And then, make marks that give you guys more than one option. Women, it's a little bit different. You also want to avoid the under the line of sight. We have more creases and folds, I'd like to say, and sometimes even like the underwear will make a fold. And then again, targeting below the ribs and in the rectus muscle, sometimes having them lay on their back and do a small sit up will help to identify those muscles, and then marking well, staying away from your creases. That really will help. And then, as you guys are probably very aware of, the wound nurses were in their education, we're told to never put convexity on a new ostomy of any kind. But now we have new soft convexity, and so that has changed. So the Colon and Rectal Society and the WCN came together, and they're saying now that from a wound nurse's perspective, it is okay to put soft convexity on a new ostomy immediately post-op. And there's many different kinds, and these are just some of the many examples. The pouching lingo, you guys will get to know. You probably know a lot of it already, but there's 1-piece systems, 2-piece systems. The thing that goes against the skin is called the wafer. They can be flat or convex. You can order them pre-cut so the patient doesn't even need to cut them. They can have a lock and roll bottom like this, or a high output bottom. So you can hook it to like a 2-liter bag. There's accessories, belts, rings, stoma paste, powders, there's adhesives. There's these new high-end skin protectants. There's 2 on the market, and they're amazing if you have moisture-associated skin damage underneath your pouch. And then there's the dreaded belts. Most patients don't really like these belts, but they are very helpful with not only to prevent peristomal hernias, but to keep their pouching system on. And then there's the new non-belts. These are like little sticky things that go on either side of the pouch that kind of function as a belt. A million ostomy products out there. You can kind of see them all. There's adhesive sprays, there's powders, rings. This is actually bonding cement. I mean, these are serious products. And then what to do about gas. Gas is a real problem for patients. It keeps them up at night, both inpatient and outpatient. And so you really want to look at what food choices they're making. Maybe you want to add some medications, and then give them options like there's built-in filters in pouches that you can order, or you can add gas valves whenever it's appropriate. So I think we only have like a couple minutes left. And so I'm thinking that we might want to stop for questions. What do you think, Matt? Do you want to stop here, or?
Yeah, I think that's reasonable.
Okay.
All right, well, thank you very much for that. There was so much information in there, so I'm going to have to definitely watch that again to have it all sink in. We will ask people to put questions in the chat. If you have something that you really want to ask, you can also raise your hand and we can do it that way. While people are getting their questions together, I have 2 different questions for you. So the first one is, how can we, as new attendings later this year, or any faculty that are on the call, best support the wound and stoma nurses that we work with so that we can try to create another one of you?
Well, I think, talk to them and befriend them. I mean, one of the things I think we learned for sure with CARS is even just setting up a meeting once a quarter, or whatever, where you actually sit at a table and talk to one another about anything. I mean, I think we as medical people do better talking about patients, you know what I mean, rather than talking about like, how do you do what you do, or like that kind of thing. So maybe bring a couple patients. Those wound nurses are dying to know what's inside your heads and how they can do to help. So let them know who you are, know your face, say hi to them in the hall. I mean, simple things like that.
Great. When you reflect on all the surgeons that you've worked with and you think of the best ones, what did they do with and for patients with difficult stomas or fistula that really made them stand out to you?
Well, I think that probably the ones that I was so impressed with really asked the questions that I would have asked. Like they didn't just come in and say, oh, you're having problems. Okay, I'm going to refer you to someone to take care of the problems. It was like, okay, they weren't afraid. They would take the pouch off, they'd take a look, they would, not be afraid to really get to the Gemba. Do you guys know what the Gemba is? Yeah. Are you lean management people? The Gemba is like the Toyota company. They did lean management, right? And their whole theory was, if you have a problem, you have to go to the Gemba, which means you go to the site of the problem. And so if a patient comes into your office and they're really having a problem with their ostomy, I mean, you don't want to take one off and not have anything to put back on. But I do think that a lot of times there's something going on under there that's a surgical problem, and, really exposing the issue and then talking to them, like, what does your 24 hours do? Are you up at night? Are you up in the morning? Oh, you're drinking a liter of vodka? Well, that might be it. I mean, those kinds of things.
Yes, that makes a lot of sense. One question from one of our other co-leaders. He says, incredible talk and scope of knowledge about when to use VACs. And he wanted to clarify that the VACs that you are showing are not actually on the os of the fistula. And then he was also wondering when wound VACs are best introduced for large fistula wounds.
I love whoever this person is. I can't say the name, but yes, I'm sorry I didn't make it clear. You never ever vac on bowel, whether it's a fistula or an ostomy. You should never put the negative system, the foam, on the fistula. You always are isolating it with whatever you have. I mean, there's isolation devices out there from Fistula Solution. You can use barrier rings, you can make your own. People use baby bottle, nipples, but always isolate the fistula so that there's no negative pressure on it, and let that stool come out into a pouch. So that's the first part. And then the second part was best introduced for large fistula wounds. I would say VAC dressings can only be effective when the patient's holistic care or holistic condition is good. So you can put a VAC on a big abdominal wound with a fistula, and it helps you to contain stool and all that kind of stuff. But really what you're trying to do with the VAC itself is contract the wound, prepare it for the next step. You know, it's probably not going to come all the way together, so you're going to probably be preparing for a skin graft. So make sure they have good nutrition, you know, all the other factors are under control before you deploy negative pressure. Otherwise, I feel like sometimes you can actually create more fistulas because there might be some kind of under the surface and the patient's pretty ill, and then you're pulling that negative pressure. So that would be my suggestion.
Thank you. We have a question from Sir John from Dr. Schenker. She's asking who forms the complex fistula team? Like who are the members?
The members, like that second slide that I showed you, we had 3 general surgeons, 1 minimally invasive, 2 open, and then we had myself as like a nurse navigator. My title is complex abdomen specialist, but primarily I was like the navigator that kind of helped everything move around. And then we had a specific PA that worked with us. And then we almost always had a resident physician on our team in the rotation. We always had a PA student. We do a lot of teaching. And then we had a nutritionist. We'd bring in the case managers if we had issues. We had a pharmacist. And between all of those people, and then of course we had leadership that supported us. They didn't come to the meetings. Well, sometimes they came to the meetings, but that was our team.
And speaking of wound vacs, Dr. Hill, another one of our co-leaders, asked, do you use a combination of white and black sponges for these complex fistula wounds, or do you find just black sponges work fine?
Well, it wasn't a lot in this presentation, but we now do installation negative pressure. So there's a new foam out that allows fluid to go through the foam and then come back out. And it's like a dishwasher situation. And in our fistula-based big wounds and any of our big wounds, our neck fascia wounds, burns, we're using this new installation. And so we don't use white or black foam. It's reticulating open cell, but it's hydrophobic compared to the black foam that's hydrophilic. And so that's what we've really moved to because it actually progresses them quicker. We're seeing less edema, more granulation tissue, and it makes sense because you're washing that wound bed. So even if you get some particulate matter in there, you wash it out with the next, exchange. So that's our new standard of practice at the facility that I work at.
Okay. She had a secondary question on an outpatient basis. For example, these patients that are going home for months in between surgeries, are you checking labs? And if so, how often to monitor nutrition? Or are you mostly looking at patients' weight?
No, we do. We check labs. So in the CARS program, we see every patient once a month. And that's a combination of myself and the surgeon. We have a combined clinic, which is really nice because then we can actually draw labs when they come in. So our labs are, once they're discharged, once a week for the first month, and then once a month until they're repaired. But if they're a high output and we're doing fluid infusions at home, or we're running TPN a couple nights a week, then obviously we'll do the labs more often, depending on what the patient problem is.
Got it. All right. Well, I think those are all the questions that we have. Any final thoughts or tips for us?
I just am so excited about you guys getting out to practice. And Matt, please give them all my cell phone number and my email. And with all my heart, I mean it. If you have a problem and you just need someone to kick around an idea, I will always take a call.
Thank you. I will definitely do that. I did actually have one lingering question. Do surgeons ever come to the WOC meetings that you have?
You know, we have resident surgeons will present there frequently. And so I think that that's something that if you're interested in, I'm on the board of that and the Society for Advanced Wound Care. And if you guys ever wanted, anyone would be interested in talking about anything that's in your practice, I think it's always loved to be heard about. So yeah, I guess the answer is, yeah, that'd be great.
Cool. I realized that, you know, once I finish training, how am I going to figure out more about all these wounds? So it might be a place that I want to go check out.
I should tell you, I do have a website. It's complexwounds.com, right? Is that what it is? It's on the bottom of my email. And I have YouTube videos. Literally, I have a YouTube video on anything you can possibly think about when it comes to fistula or complicated back placements. And so it's obviously, you know, for free or whatever. So if Matt, you want to send that out, I think it's on the bottom of my email, what the website is. I can't remember what it is. But.
Perfect. I'll definitely include that. Well, thank you again, Mary Anne, for everything you taught us today. Next week, we will be welcoming Dr. Stefan Holobar from the Cleveland Clinic, and he's going to discuss bowel preserving surgery and Crohn's disease. In case you missed it, he did participate in a DCR Journal Club debate in November. So check out that in preparation for his talk, and I'll tweet out that link later this week. Good night, everyone.
Good night.